Consider a 27-year-old female patient with systemic lupus erythematosus. She has been in remission for 12 full months and strongly desires to start a family. To maintain that remission, her immune system is currently stabilized on a daily maintenance therapy of azathioprine and low-dose prednisone. When conception occurs, the immediate instinct for many patients, and even some clinicians, is to abruptly stop these immunosuppressants. The intent is to protect the developing baby from medication exposure, but abrupt withdrawal triggers the exact scenario we have to avoid. Removing maintenance therapy allows the maternal immune system to rapidly reactivate, triggering a severe disease flare that directly threatens both the mother and the viability of the pregnancy. This clinical dilemma framework highlights the specific danger of abruptly discontinuing prednisone. A successful lupus pregnancy requires at least 6 months of absolute disease quiescence prior to conception, maintained by stable medication rather than sudden cessation. The anxiety around continuing prednisone specifically during the first trimester often stems from a misunderstanding of the placental environment. Looking at this diagram of the molecular safeguard mechanism, we see the syncytial trophoblast layer contains a biochemical shield, the 11-beta HSD2 enzyme. This actively intercepts maternal prednisone, converting 90% of the active drug into inert cortisone before it crosses into fetal blood. Biology provides a dedicated gatekeeper. The mother retains the systemic immune suppression she needs, while the fetus is naturally shielded from toxic steroid levels. Beyond steroids, managing lupus in pregnancy relies on this specific pharmacotherapy matrix, sorting medications into safe maintenance guardians and hazardous teratogens. The safe guardians are essential. Hydroxychloroquine is mandatory, cutting maternal flare risks in half. Azathioprine remains safe because the fetal liver lacks the enzyme required to activate it. And low-dose aspirin is introduced at 12 weeks for preeclampsia prophylaxis. The right side of the matrix shows the severe teratogens: mycophenolate mofetil, methotrexate, and cyclophosphamide. Because these cause major facial, neural, and skeletal malformations, they must be completely discontinued well before conception. Navigating pharmacology during pregnancy means meticulously swapping these known hazards for biological guardians to ensure continuous maternal protection. Even with perfect medication compliance, we have to monitor for an invisible serological threat. Maternal anti-Ro and anti-LA autoantibodies can freely cross the placenta. This antibody profile details the physiological consequence. These antibodies target the fetal heart's atrial and tritsular node, creating a risk of congenital heart block. To counter this, teams follow the surveillance protocol shown, performing serial echocardiography between weeks 16 and 26. This acoustic surveillance acts as an early warning radar. It allows clinicians to detect minor PR interval prolongations early, providing a window to intervene before they progress to irreversible complete heart block. A successful delivery removes the immediate fetal risks, but the mother immediately enters a highly volatile immunological window. Upon birth, the massive, protective, anti-inflammatory shields provided by the placenta suddenly vanish. This trajectory chart illustrates the postpartum trap. As placental steroids crash, the body experiences a sudden surge in prolactin to induce lactation, which simultaneously hyperstimulates autoreactive B cells. This inevitable biological ambush is exactly why maternal maintenance medications must never be prematurely stopped. Without them, the mother is left completely defenseless against this postpartum flare. These summary pearls recap the 3 unshakable rules of lupus pregnancy: enforce the 6-month remission rule, continue hydroxychloroquine unconditionally, and utilize strict fetal echocardiogram surveillance for anti-Ro positive mothers. When these pharmacological and reproductive pathways are carefully managed, the statistical payoff is clear. More than 98% of babies are born completely healthy. Navigating lupus in pregnancy relies on applied clinical science to confidently protect 2 lives simultaneously.